Hello friends, welcome to a new topic on cytogenetics. And today the topic of discussion is AML with translocation 821 Q22 Q22. Translocation 821 Q22 Q22 is one of the most common cytogenetic abnormalities in acute myeloid leukemia, that is AML. WHO classification categorizes AML with recurrent genetic abnormalities and is classically associated with FAVM2, that is AML with maturation. So translocation 821 is belongs to FAVM2, that is AML with maturation. AML with translocation 821 generally shows maturation arrest in the neutrophilic lineage. Coming to epidemiology, this translocation 821 found 5 to 12% of all AML, and it is more common in younger patients, and the median age is 30 years. Coming to cytogenetics in translocation 821, so here two chromosomes are involved. One is chromosome 8 and another one is chromosome 21. So the band location is q22 in case of chromosome 8 and q22 in case of chromosome 21 also. And the genes present here are RONX1, formerly known as AML1, that is present in chromosome 21, and another gene is RONX1T1, formerly known as ETO, and that is present at chromosome 8. So RONX1 gene present at chromosome 21 q22 and RONX1T1 gene present at chromosome 8 q22. Now, due to translocation of RONX1T1, the fusion protein formed is RONX1T1, which is a chimeric protein, and this chimeric protein mainly located in the nucleus of the leukemic cell, and this protein acts as a transcriptional repressor, which is nothing but a core binding factor complex, which is essential for normal hematopoiesis and thereby blocking differentiation and promoting leukemogenesis. So this chimeric protein acts as a transcriptional repressor and thereby blocking differentiation and promoting leukemogenesis. So this is the example of a metaphase showing translocation 821. So this is chromosome 8 and this is chromosome 21. So at chromosome 8 the gene location is q22, so it will be here only at the QR, and position will be q22, 2 region and 2 is the band position. Okay, so q22. Similarly at chromosome 21 the gene location is 21q22, so it will be in q arm only, and anyway this chromosome 21 is the acrocentric. Okay, so there is a break at chromosome 8 q22 here, and there is a break at chromosome 21 q22 here. So the breakage part will be exchanged between chromosome 8 and 21. 1. So there is a break here, and the remaining terminal part, it will move to the chromosome 21, and there is a break here at chromosome 21 q22, and the terminal part, it will goes and attach to the chromosome 8. So due to this reciprocal translocation, the abnormal 8 chromosome will be smaller in comparison to the normal chromosome 8, and the abnormal chromosome 21 will be bigger in comparison to the normal chromosome 21. So due to this translocation 821, the metaphage will be look like this. The abnormal chromosome 8 will be smaller in comparison to the normal 8, and the abnormal chromosome 21 will be bigger or larger in comparison to the normal chromosome 21. Okay, so the cells that possess translocation 821, it also shows some secondary chromosomal aberration, means some extra chromosomal abnormalities, and the examples are loss of chromosome Y, loss of chromosome X in female only, deletion 9q, trisomy 8, deletion 7q, derivative chromosome 21 formed due to translocation 821. Regardless the presence or absence of additional abnormalities, patients exhibit good response to treatment. It means if the cells possess translocation 821 and presence of any of these, still the response will be good only. Okay. Mutations of ASXL1, KIT and NRAS genes found in 10 to 15% of cases. So this 10 to 15% of cases shows mutation of all this gene. Okay. Complex translocation, that is formed between translocation 821 and there is a variable chromosome. It's seen in 5% of cases. Now here in 10% of RONX1 T1 positive cases harbor hidden insertion. Thus AML with morphologic, immunophenotypic or clinical features strongly suggesting the presence of a translocation 821 not observed by chromosome bending analysis should definitely screen by targeted FISH or RT-PCR analysis. It means 10% of cases showing hidden insertion, 821 hidden insertion. Okay. So if morphology, immunophenotypic and clinical features suggesting of 821, then we should go for FISH or RT-PCR analysis to find out the hidden insertion. Coming to morphology, the cells having translocation 821 shows large myeloblast with abundant basophilic cytoplasm, prominent eosinophilic granules, and frequently seen or rods. Coming to immunophenotypic, the typical myeloid markers are positive for CD34, HLA-DR, CD13 and MPO. Among aberrant markers, CD19, PAX5 weak expression may also seen, and CD56 expression of CD56 occurs in a subset of cases and is associated with higher risk of relapse. Coming to prognosis and risk stratification. So translocation 821 comes under favorable prognosis. Patients with translocation 821 generally have a higher rate of complete remission and better overall survival compared to other AML subtype. Okay, in comparison to the other, this AML this AML with translocation 821 shows favorable prognosis. Coming to adverse modifier, the presence of c-KIT mutation is mainly seen in 20 to 25% of cases significantly worsen the prognosis, potentially downgrading the risk status to intermediate. Testing for KIT mutation is mandatory in these patients. So, the presence of c-KIT mutation uh, gives to intermediate prognosis, and testing for c-KIT mutation is mandatory in these patients.